Tavan, we are live now.
Just 1 second. Okay. Now you can start. You can start. Absolutely.
So good evening, doctor. I Shuman on behalf of Shield Healthcare, welcoming you all in today's webinar. And the topic of today's webinar is uterine factor in female infertility. And our guest speaker is Dr. M. Madhavi, madam. Before moving into the webinar, let's have a look on our Shield Connect page. This is our Shield Connect page. It's basically a knowledge sharing platform of Shield Healthcare. Here you can find different blogs written by many eminent doctors across India in different topics as well. And these are the past webinars already we have conducted in our platform in various topics. And this is the PCOS awareness blog. Here you can find different talks related to the PCOS only given by many eminent doctors across India. And this is the most relevant blogs, that is COVID-19 awareness blog. Here you can find different topics related to the COVID-19. And the most important thing is our key opinion leaders. Almost 300 doctors are currently supporting us this knowledge sharing platform, Shield Connect. And now it's time to start the webinar. And it's my pleasure to introduce Madam, although Madam doesn't need any kind of introduction, just I'm briefing a few of it. Madam did her MBBS, DHUF, MAS, and FRM. Madam is the senior consultant and gynecologist and obstetrician and laparoscopic surgeon in Hyderabad. So with this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for their active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you, Madam, and over to you now.
Namaskar. I thank Shield Connect for giving me this opportunity to talk on this topic, uterine factors in infertility. I welcome all the delegates, and I hope to do justice to your time spent here. Yeah. So my topic given to me to talk on is uterine factors in female infertility, as we come across in our daily day-to-day practice with so many women and couples trying to conceive. One of the important factors which is responsible for infertility. I will walk through some of the uterine factors apart from, so I will not talk on any of the ovarian, about the tubes and anything to do. I will totally concentrate on the uterine factors in female infertility. Now, infertility, that is failure to conceive following 1 year of unprotected sexual intercourse or more than 1 year. Now, these causes could be male, contribute to 35%, unexplained 15%, female almost 50%. In female, we have uterine, fallopian tubes, and ovarian causes. Now, in ovarian causes, you have the decreased FSH, normal FSH, and increased FSH. Hypothalamic, there are different reasons for the decreased gonadotropins. They are the hypothalamic and hypopituitarism. But my point of discussion today talk is restricted to uterine factors. Uterine factor infertility may act upon 1 in 500 reproductive age women. The uterus has a crucial role in allowing for a woman to achieve pregnancy and carry to term successfully. Assessing for uterine factors in infertility is essential when a patient first starts the treatment for infertility. So our immediate workup starts right from the first sentence. We ask them, are your periods regular? If she says she has attained menarche or not, or she's into primary amenorrhea. So that is where it raises an alarm as to is there any uterine factor? So when a patient first presents, that is where we get to know, is she menstruating or not? There are many etiologies of UFI, but to categorize the diagnosis into either congenital or acquired in origin, clinicians may achieve a clearer understanding. Now, we divide them into congenital anomalies, uterine anomalies, and the other ones are the acquired. In congenital uterine anomalies, in 1800, Kruvier and von Rokitansky first described congenital uterine anomalies. The prevalence of these anomalies remain unclear, as many women may go undiagnosed. So it is so very strange, unless a girl reaches the age of menarche or 12, 14, 16 years, it really goes unnoticed and undiagnosed. And it is estimated that almost 0.5% of the women are affected in the general population and 3 to 13% in the infertile population. As the risk is increased in the infertile population, providers should have a high suspicion when assessing patients that present for infertility. An accurate diagnosis is important, as each anomaly has differing reproductive outcomes and treatment options. Now, let us go to the embryology, how it starts with the female genital tract. Between 8 to 16 weeks of gestation, the uterus develops from two Mullerian ducts in a process called organogenesis. As these ducts develop, they fuse to create the upper vagina, cervix, and uterus. After the ducts fuse, the central septum gets reabsorbed, allowing for a single cervix and uterine cavity. A failure in any step will lead to the congenital uterine anomaly. The etiology behind this failure is unknown, and there have been no genetic linkages identified. So here we have, that is the estrogen that is secreted by the maternal and the placental sources. It helps in the development of extragenital organs like labia, clitoris, lower portion of the vagina, whereas paramesonephric ducts stimulate the uterine tubes, uterus, upper portion of the vagina. Now, modified American Fertility Society classification, according to them, they diagnosed as class 1 dysgenesis of Mullerian duct, class 2 disorders of the vertical fusion, and transverse vaginal septum, obstructed, unobstructed, cervical agenesis, dysgenesis, class 3, that is disorders of the lateral fusion, asymmetrical, obstructed disorders of uterus or vagina with bilateral renal agenesis, either a unilateral or bilateral renal agenesis, uniconvate uterus with non-communicating rudimentary horn, upper or lower obstruction of the cavity of double uterus, upper and the lower vaginal obstruction associated with double uterus. Now, B, symmetric unobstructed diadelphic uterus, complete longitudinal vaginal septum, partial longitudinal vaginal septum, no longitudinal septum. Now, the septate uterus, that is the complete, partial, biconvate uterus, complete or partial, T-shaped uterine cavity, uniconvate uterus with a rudimentary horn with the endometrial cavity communicating, non-communicating, without endometrial cavity without a rudimentary cavity. So class 4, unusual configuration of the vertical lateral fusion. Now, what was the criticism according to the AFS classification? That it's a complex genitourinary anomalies. Class 1, very general, obstructive anomalies due to the cervical or the vaginal aplasias are not represented. So now the ISHRI and ESG group classification on the basis of anatomy. Deviation of anatomy deriving from the same embryological origin are the basis for the main classes. Clinically significant anatomical variations, basis for subclasses. Now, the cervical and vaginal anomalies, supplementary subclasses. So they were just concentrating initially only on the uterine, but there were anomalies associated with the cervical and the vaginal features also. So Ishre and ESG classification, according to them, the female genital tract anomalies that is classified as U0, that is a normal uterus, where you have a normal cervix. U1 is a dysmorphic uterus, either T-shaped, infantilis, others. C1 is a septate cervix, C2 double normal cervix, C3 unilateral cervical aplasia, C4 is the cervical aplasia. Now, U2 is a septate uterus, which could be a partial or a complete septum. At the same time, with this, you have U3 bicorporeal uterus, which could be a partial, complete, bicorporeal septate. Now, U4, that is the hemi-uterus with rudimentary horn communicating or not horn, or no horn is there without rudimentary horn. That is the horn without cavity, no horn is there. Now, U5, that is the aplastic with rudimentary horn, bi or unilateral horn. Now, U6 is the unclassified malformations. Here, according to V0 is the normal vagina, V1 is the longitudinal non-obstructing vaginal septum, V2 is the longitudinal obstructing vaginal septum, and V3 transverse vaginal septum or imperforate hymen. V4 is absolute vaginal aplasia. So these are what we have. They have divided the uterus, cervix, and vagina. Now, according to this, describes very, very clearly about the normal uterus. How it appears, it is the straight, this part is the straight or a curved interostitial line. Internal indentation at the fundal midline not exceeding 50%. So that comes as a normal uterus, where we have the septate uterus, internal indentation at the fundal midline that is exceeding more than 50% of the uterine wall thickness. Unilateral uterine development, that is the contralateral part, could be either completely formed or absent. Now, here we again have the narrow uterine cavity due to the thickened lateral walls. These are the lateral walls, and then you have the infantile uterus. External indentation. This was all about the internal indentation into the uterine cavity. How you see the external indentation. So what this group is called as class U3 is the bicorporeal uterus. That is the external indentation at the fundal midline exceeding more than 50% of the uterine wall. And then you have the aplastic uterus, that is absence of any fully or unilaterally developed uterine cavity. So U5 is the aplastic uterus. Now, MRKH is something to do with, this is the normal uterus, cervix, here's the bladder, rectum, and this is the vaginal canal, normal full length, and this is the normal. On both sides, you have the ovaries. But in MRKH, what exactly happened? You have the normal ovaries. Some patients will develop a non-functioning uterine remnant. It's like a nodule, or you can just see as a bulb. Now, this is what the bladder and the rectum fuse together. This is the fusion of the bladder and rectum, where this is a total, absolutely, this is a place of uterus, cervix, and vagina. You can just see as a vaginal dimple. Now, the external genitalia are well developed. Now, here comes anomalies associated with MRKH. There could be little variations, where we have the urologic anomalies, that is 15 to 40% unilateral renal agenesis, ectopic or horseshoe kidneys, duplication of collecting systems, hydronephrosis, skeletal malformations 10 to 15%, hemivertebra, supernumerary vertebrae, vertebral fusion, syndactylia, scoliosis, Klippfield syndrome, which includes a short neck, low hairline, limited range of the motion, and neurologic symptoms resulting from. These are some of the variations of the MRKH. Now, in type A, where uterus does not develop fully, we have the normal ovaries, underdeveloped vaginal canal, that is vaginal ergenesis, undeveloped organs in MRKH. So these are some of the variations. Whereas in type B, there is absence of the kidneys, where you have hypertrophied, compensatory hypertrophy of the other kidney. Now, there is rudimentary fallopian tube, cystic ovary, right uterine bulb, normal ovaries, rudimentary fallopian tube, left uterine bulb, round ligaments, and again you have no urethral orifice. So these are some of the variations in MRKH. Now, what do we have? What is the solution for it? Management is creation of a functional vagina, and then option of surrogacy is given to her. Difficulties using, now, even in cases where the neovagina is formed, there is a difficulty during ovum pickup, lack of vaginal elasticity, and surgically reconstructed, that will have a lot of fibrosis. And the organs, that the ovary is also very difficult to locate because they are ectopically located gonads. Now, we have the classification of unicornuate uterus. One is the communicating. Here, this is a unicornuate uterus with the communicating horn. Here, we don't find any sort of communication. There is no cavity in the horn at all. So there is just the unicornuate with no cavity, and the other one is no horn at all. Now, the infertility perspectives are variations in the vascular contributions, extent of the reduction of muscular mass, degree of cervical incompetence, and coexistent pelvic diseases such as endometriosis. Conception rates were not significantly seen. Now, pregnancy perspective, you have the pregnancy complications. Rates were quite high, like 24.3% first trimester miscarriage, 9.7% second trimester miscarriage, 20.1% preterm delivery, 10.5% intrauterine fetal demise, and single embryo transfer is highly recommended in these women, because the musculature mass, the muscle mass itself is not such strongly developed as to hold multiple pregnancies. So in such cases, single embryo transfer is highly recommended. Need for surgery? Yes, of course, for functional rudimentary uterine horn removal has become an accepted approach, surgical approach for dysmenorrhea, ectopic pregnancy in such patients. Bicornuate uterus. So here, bicornuate unicollis. That means this is a single cervix. Here you have bicornuate bicollis. You have two uterine cavities. Here it's a single uterine cavity. How to differentiate between the diadelphous uterus? Now you see, this is bicornuate bicollis. Bicornuate bicollis. Here you can see two cervices, whereas bicornuate bicollis, this is again two cervices having with the vaginal septum. Now, most women with this anomaly have no difficulty conceiving, increased risk of mid-trimester pregnancy loss and preterm births. Metroplasty is reserved for women who have experienced recurrent spontaneous abortions, mid-trimester loss, premature deliveries, where no other associations are seen, ruling out, yes, other reasons of pregnancy losses, where you definitely pinpoint to such things. So where the cause being in those patients, metroplasty is reserved for women who have experienced it. Now, single embryo transfer is highly recommended. Replacement in the uterine cavity, which has better ultrasound endometrial appearance and capacity and easier access. Septate uterus, septal endometrium compared to endometrium of the lateral uterine wall has reduced number of the glandular ostia, reduction of the ciliated to non-ciliated cell ratio, poor response to estrogen, increased muscle tissue and uncoordinated contractility, defect VGEF receptors, inadequate uterine vascularization leading to subsequent abnormal placentation. Now, in women with septate uterus, however, the probability of pregnancy was significantly decreased compared to normal controls. So, metroplasty versus the expectant management for women with the history of miscarriage and a septate uterus, no grade A evidence on the efficacy of hysteroscopic metroplasty in recurrent miscarriage. The available evidence is biased because women are being used as their own controls. Surgical treatment of these women should be discouraged unless this treatment is performed as part of the randomized control trial. So the consensus says that yes, hysteroscopic metroplasty may not give us benefits. So that has to be discouraged. Incidence in infertile group same as compared with other. More common in women who have had recurrent pregnancy loss or the pregnant or preterm births. The hysteroscopic metroplasty has not been shown to increase the pregnancy rates. Further research is needed to evaluate any benefit on live birth rates of surgical resection in infertility patients. Now, diadelphous uterus was not related to decreased conception rates or increased second trimester miscarriage, but preterm labor and malpresentations at deliveries were increased. Compared with other uterine anomalies, diadelphous uterus has a relatively good prognosis for achieving pregnancy. Now, surgical metroplasty should only be considered on a case-by-case basis. In the case of obstruction, dyspareunia, or infertility due to a coexisting vaginal septum, the septum should be removed. Arcuate uterus, the arcuate uterus is considered a subtle abnormality or a normal variant. Surgical correction is not recommended. Acquired uterine factors and infertility, so these were the groups of congenital. Now where we have is the acquired groups. So they are like endometrial polyps. Endometrial polyps are aberrant endometrial growths consisting of glands, stroma, and blood vessels with a vascular center and sessile or pedunculated shape that extends into the uterine cavity. They range in size from few millimeters to several centimeters and can be found in isolation or multiples. So now, how it affects fertility? One is because it causes mechanical impact. Then at the same time, it has inflammatory effect. Now the lower leukocyte density, mast cell activity, recruitments of T cell, low endometrial NK cells. Endocrine, increased estrogen receptors, low progesterone receptors, low IGF-BP and 1 and osteopontin. Cellular level, increased proliferation, inhibition of apoptosis and chromosome as well. So some of the women have the tendency to form the endometrial polyps. Now the size and location of the polyp also is important. Endometrial polyps less than 10 millimeter in symptom-free patients prior to ART expectant management may be given that spontaneous regression following a menstrual cycle has been observed. Now, conversely, endometrial polyps more than 15 millimeter are less likely to regress spontaneously. Now, excision of those at the uterotubal junction is associated with significant improvements in the pregnancy rates. So the one near the uterotubal junctions, once they are cleared or they are just, during cannulation, they are taken care. So the pregnancy rate almost increases. According to AAGL, increasing age is the most common risk factors, that is the level B. Study shows abnormal uterine bleeding is the most common presentation. Infertile women are more likely to be diagnosed with an endometrial polyp. Polyps may naturally regress in up to 25% of the patients. Medications such as tamoxifen may predispose to the formation of the endometrial polyps. Management, conservative management is reasonable, particularly for small polyps and if asymptomatic. That is the level A study shows, and medical management of polyps cannot be recommended at this time. Hysteroscopic polypectomy remains the gold standard for the treatment. For infertile patients with polyps, surgical removal is recommended both in natural and ART cycle to have a greater opportunity of the success. Now, adenomyosis. Adenomyosis is the presence of endometrial glands and stroma distal to the endometrial myometrial junction. Now, the amount and degree of the invasion vary, and glandular deposits can be diffuse or circumscribed and focal. It is associated with endometrial smooth muscle hypertrophy. Etiology is unclear, but the most accepted theory is invagination of the endometrial basal layer into the myometrium. So that is the most important, invagination of the endometrial basal layer into the endometrium. Approximately 20% of the patients are diagnosed in women younger than 40 years. Clinically, it manifests as menorrhagia and dysmenorrhea in those that are symptomatic. However, many are asymptomatic. Severity appears to be correlated with increased number of ectopic foci and extent of invasion. Now, there are different sonographic features. So the appearance of globular, now that is considered as a third eye of the gynecologist. Ultrasound has totally revolutionized the approach towards any gynec pathology. So what does the ultrasound features of adenomyosis show? As a globular uterine configuration, poor definition of the endometrial myometrial interface, subendometrial echogenic linear striations, myometrial anteroposterior asymmetry, intramyometrial cyst, then heterogeneous myometrial ecotexture. Now, here we see is number one is this is the endometrial lining, hyperechoic, what we take it as it should be central, whereas these are some of the subendometrial halo, that is the junctional zone, that is very, very important, and myometrium with homogeneous ecotexture. This is what the normal appearance. But in most of the cases, there is asymmetry in anteroposterior wall. So these are the different appearances. Now here we see that is in the posterior wall, you see this as a lesion. As well as here also, these are seen as the echogenic lesions. Now classification for adenomyosis based on MRI, simple junctional zone hyperplasia, that is the zone thickness more than 8 millimeter, but less than 12 millimeter, or the images in women aged 35 years or less. Partial or diffuse adenomyosis, that is the thickness more than 12 millimeter, high signal intensity myometrial foci, involvement of the outer myometrium, that is less than 1/3, less than 2/3, and more than 2/3. Adenomyoma, that is the myometrial mass with indistinct margins or primarily low signal intensity on all MRI sequences. Now, here we have is the mechanism of action, altered uterine peristaltic activity, the loss of nerve fibers at the endometrium myometrium interface, and absence of the nerve fibers in the adenomyosis. Smooth muscle cells from uteri with adenomyosis are ultra structurally different from smooth muscle cells of the normal uterus. altered endometrial function and receptivity, altered decidulization, abnormal concentrations of intrauterine free radicals. So these are the different causes of infertility due to adenomyosis. Now, adenomyosis was associated with 28% reduction in the likelihood of clinical pregnancy in infertile women who underwent IVF ICSI with autologous oocytes. Now, how do we manage adenomyosis? The different options are medical management, GnRH analog, estrogen, progesterone. Now, danazol is obsolete. LNJ-IUS is the best medical option. Surgical are adenomyomectomy, uterine embolization, and high intensity ultrasound waves, that is also HIFU, is another modality of the treatment. GnRH in adenomyosis, how does it work? It reduces the inflammation and in turn reduces TGF, and thereby reduces VEGF, and thereby reduces angiogenesis, proangiogenesis, and the GnRH agonist works in different, it increases apoptosis and reduces the oxidative stress. So this is the action of GnRH in adenomyosis. Junctional zone. Why do we talk so much about the junctional? How important it is as a new marker of implantation. Now, MRI evaluation of junctional zone thickness is the best negative predictive factor of implantation. In patients with junctional zone with less than 10 millimeter, the pregnancy rate was 45% per transfer, while rates as low as 16% and 5% were observed with junctional zone thickness of 10 to 12 millimeter or more than 12 millimeter respectively. So this is supposed to be the junctional zone thickness is the best negative predictor for the implantation. Now we come to fibroids. Uterine myomas, also known as uterine fibroids, are benign smooth muscle tumors originating from myometrial tissue classified based on their anatomic location. Grossly, they are pearly white, firm, well-circumscribed tumors which are relatively avascular but surrounded by a rich vascular system. On histology, they are comprised of smooth muscle cells aggregated in whorled bundles. On histology, they are comprised of smooth muscle bundles aggregated in whorled bundles. The prevalence of these tumors increases with age, which becomes significant as more women are delaying childbearing. Uterine myomas can be identified in 20% to 40% of all the reproductive age women. Fibroids are noted in 80% of the Black women and almost 70% of the white women by their late 40s. Fibroids are present in up to 27% of the patients seeking reproductive assistance. And there is a clear consensus that submucosal fibroids, which inherently distort the uterine cavity, have detrimental effect on fertility with decreased clinical pregnancy rates and delivery rates. Submucosal fibroids have been shown to increase the risk of giving rise to clinical abortion more than threefold. So this is one of the reasons why they are more at risk of abortions. Now, fibroid tumor. Fibroid uterus is like subserous fibroids, no obvious fertility issues. Subserous, it doesn't interfere with the, as such, the woman can carry with the pregnancy up to term. Submucous fibroid, yes, poorer reproductive outcomes. Myometrial myomas, they have may have poorer reproductive outcome. Lack of quality evaluation make this conclusion tenuous at best. So the most important of all the fibroid which we should be concerned is about the submucous fibroid, which has a poorer reproductive outcomes. Now, the treatment options we have is like ranging from the medical therapies that have been shown to decrease the uterine fibroid size and thereby symptomatology, to uterine artery embolization leading to necrosis, and surgical interventions with mimectomy and hysterectomy. In patients with fibroids felt to be contributing to infertility, surgical removal by mimectomy is the most appropriate option. As reviewed above, the surgical intervention is best optimized by preoperative imaging to determine the precise size and location of the myoma. The decision to operate should not be made without consideration of potential risks, including ongoing infertility despite surgery, potential deleterious outcomes in subsequent pregnancy, and committing a patient to cesarean delivery at 37 to 38 week to avoid risk of uterine rupture during labor. Uterine artery embolization is not recommended for women intending future pregnancy, as the rate is up to 64% and rate of abnormal placentation is almost about 12.5%. Post-embolization, successful pregnancies can occur, but long-term data are limited. When surgery is chosen for women, adherence to basic microsurgical principles with gentle tissue handling, meticulous hemostasis, and minimal exposed suture help ensure best surgical results. Vasopressin or uterine artery tourniquets to assist the hemostasis can be used. Hysteroscopic mammectomy. Hysteroscopic mammectomy is the first line for the symptomatic submucous fibroids whenever possible. It is appropriate for submucous fibroids up to 5 centimeters in size. Complete resection is routinely achieved in all fibroids with more than 50% of the fibroid intracavitary. In fibroids where less than 50% is intracavitary, they may require multiple procedures for complete resection or have more complete resection with abdominal removal, and patients should be counseled accordingly. Each case should be individualized to patient location and the number of the fibroids and overall goal of the surgery. Several techniques are available for hysteroscopic mammectomy, which include morcellation, electrocautery resection, laser ablation, and vaporization. Electrocautery resection can be performed with monopolar energy, which requires a non-conductive distension media, such as glycine, or bipolar energy, which can be done with saline also. Risk of these procedures include inability to completely resect the fibroid secondary to fluid deficit, uterine perforation, and the potential for injury to other organs and subsequent endometrial scar formation. Hysteroscopic morcellators include the true clear hysteroscopic morcellators and myoshear tissue removal systems. So there are different ways of with considering electrical and non-electrical with morcellators. So mechanical methods, there are different ways of hysteroscopic mammectomy. Now, here we come across what is the clinical pregnancy rate associated with the intramural. Intramural, it is almost 409 per 1,000, whereas submucous, here definitely the pregnancy outcome is lesser. So as compared to intramural and subserous, again, here you see 214 per 1,000, whereas the miscarriage rates, they are like low in intramural, and that's how the submucous, it is much, much higher. So overall systematic review, which included 6,087 IVF cycles, found that presence of non-cavity distorting intramural fibroids on average reduces the live birth rate by 20% and clinical pregnancy rate by 15% per IVF cycle compared with no fibroids. So this is the role of fibroid. That's how it affects the pregnancy outcome. Now laparoscopy, and we have the robotic assisted. Advantages of laparoscopy over laparotomy include improved visualization, decreased blood loss, and all the above known benefits of minimal invasive approach. There are some reports of increased risk of uterine ruptures with laparoscopy over open approach, but overall incidence appears to be extremely low. The Da Vinci robotic system has been approved for gynecologic procedures since 2005. It provides advantages of 3D visualization, intuitive wrist-like movements, and minimally invasive approach for mimectomies that may have otherwise required a laparotomy. Disadvantages, however, include increased operative time and cost. Now, intrauterine contractions. In late follicular phase, there is progressive increase in the uterine contraction frequency under the estrogen influence. Mainly involve the subendometrial layer of the myometrium not perceived by the woman. Contraction frequency reaches highest just prior to ovulation, that is 5 per minute. Cervix to fundus transport predominates with preference to the side-bearing developing follicle. So here we see the number of contraction during it is reaching right up to 5 just before the ovulation, and then the contraction goes down, and then ET, and that's how the contraction level of the uterine contraction goes down as post-follicular phase. Now, clinical pregnancy rates in IVF, here we see is almost less than 3 contractions per minute. Then the percentage is almost about 60%. 3.1 to 4, 4.1. So as the contraction increases, the pregnancy rate also goes down. So that is the importance of uterine contractions in pregnancy outcome. Medically induced, they are like hysterectomy. There are many indications for hysterectomy, which include malignancy, pelvic pain, endometriosis, abnormal uterine bleeding, pre-malignancy, and obstetric emergency. So in surveying 250 candidates for uterine transplant in United States, 64% of the patients had previously had hysterectomy for benign conditions. That is what the study says. Uterine radiation, the total body irradiation and the effect it has on fertility and the pregnancy outcome that radiation has on fertility and future pregnancy outcome is important, so clinicians may appropriately counsel patients before treatment. There is a direct relationship between the radiation dose and the risk of adverse effects in the future pregnancy. So what is the dose? A dose less than 4 gyrates does not appear to affect fertility outcomes in the future. Total body irradiation is typically 12 gyrates. At this dose, pregnancy is attainable, but is associated with increased adverse outcomes, including miscarriage, preterm delivery, low birth weights, and perinatal deaths. It is recommended after an exposure of more than 45 gyrates as an adult, pregnancy should be avoided as this dose of radiation will cause irreversible damage to the uterine vasculature and musculature. Studies have demonstrated that radiation of the uterus leads to a significant decrease in the uterine volume. In addition to radiation dosage, the timing of exposure also is equally important for predicting the pregnancy outcome. The uterus completes development 7 years after menarche. If a patient undergoes radiation before completion of the development, there is an increased risk of the damage. For this reason, those who are exposed to radiation in doses of more than 25 gyrates as children are also recommended to avoid pregnancy. Uterine transplantation. Remarkable developments have been made over the last decade in the field of uterine transplantation. The first true treatment for absolute uterine factors for infertility. Before the development of this procedure, women with uterine oogenesis or prior hysterectomy were unable to become gestational mothers. Now, what are these gestational mothers? They are surrogate mothers. So here we go, start of the uterus transplantation, the first experience that was way back in 2000, then next 2011, Sweden, 2013, where we all got to know. In China, US, this is the journey of uterine transplantation. Finally, it reached India around 2017. And next, other countries are also experiencing. As far as the ones, the live, the pregnancy outcomes have been, there have been no complications and 3 live deliveries. The number of the cases being performed is increasing dramatically with detailed outcomes from 65 cases now available. Pregnancies achieved through uterus transplantation and following in vitro fertilization are associated with an increased risk for further mother and the newborn babies. Now, reported complications in uterus transplantation procedures for the donor, like the major intraoperative, postoperative bleeding, ureteric injury, uterovaginal fistula, vaginal cuff, dehiscence, fecal impaction, leg buttocks pain, and depression. Now, for the recipients, the major is the bleeding, hemoperitoneum, vascular thrombosis, intrauterine abscess, uterine prolapse, vaginal stenosis, vesicovaginal fistula, uterine tract, urinary tract infections, fungal infections, viral infections, and organ rejection. So these are the reported complications for the donors and recipients during and after the uterine transplantation process. Gestational careers, they are a gestational career, also known as a surrogate, is an individual who receives the embryo provided by another couple and carries the pregnancy until the time of delivery. Now, a gestational carrier allows for women with uterine factors for infertility to have a biological offspring without carrying the pregnancy. Surrogacy is surrounded by legal, ethical, and social controversies. As a clinician, it is important to be aware if the particular state government that they have different, laid down policies regarding the surrogacy in order to appropriately counsel your patients. So there we conclude we have the different factors. We divide them into the congenital, acquired, and yes, nowadays we are coming with many of the MRKH cases which does not show any of the genetic links. The gonads are well developed, the external genitalia are well developed. Now then, we can definitely give them an option of, most of them about a decade back, they used to come after getting married, but of late when they have not attained menarche, the patients are picked up little early, and yes, we need to give them different options. Now, these are the congenital. The acquired ones, the polyps, yes, which to operate, which not to operate, the multiple polyps, fibroids, adenomyosis, uterine contractions, fibroids, and these are the different factors which we need to have in-depth knowledge so that we can counsel the patients better and give them a proper, we need to walk the path with them to make them feel, yes, there is still hope for their the pregnancy outcomes and a beneficial, giving hope to the couples with giving good pregnancy rates. And it's just not the woman getting pregnant. Yes, we have to have a good neonatal outcome as well. And yes, of course, we should be knowing about the uterine transplantations and gestational careers. Those are the surrogate mothers. Thank you for patient hearing.
Thank you very much, madam, for this nice presentation. As we understood that uterine is the most important factor, it's almost one of the important factor for the. Give me 1 minute to collect the questions from the dashboard. Ma'am, if you allow me, then we can move on that.
Yeah, sure.
Okay, ma'am. Ma'am, the first question is if the congenital uterine anomaly is diagnosed, so in that case, means what will be the first approach to treat the patient in terms of the infertility?
See, in that case, we just need to do even a simple high resolution ultrasound gives us a lot of information. We need to make sure about the size, endometrial lining, the myometrium, all that has to be very well, the has to be proper study of the ultrasound imaging. And with nowadays 3D and 4D, the need for MRI and CT contrast has definitely gone down. So we can send the patient to for the 3D and 4D ultrasound, which gives us really a lot of information about the volume also, which cannot be picked up in 2D ultrasound. That is one of the commonest. And yes, before subjecting to any interventions, we should give them non-invasive options more and evaluate the anomaly or whatever we have, the uterine factors. So with all these imaging techniques, we have improved outcome, and we have to make sure, yes, this is the septum which requires resection, or which can be, if she has had a previous birth and then later they are picked up on HSGs or hysteroscopy elsewhere. So we need to make sure, yes, does she really require any sort of intervention?
Okay, ma'am. Thank you.
So a good high resolution 2D ultrasound, the real time is one. And if still that is not picking up, we send them for MRI. But yes, nowadays we have very excellent sonologists doing our 3D and 4D. They give a lot of information about it.
Okay, ma'am. Ma'am, another question is, what is your opinion on the uterine transplantation? It is the last as the last step to follow, or in what cases you can move for the uterine transplantation, which is a very emerging.
See, we have in patients with definitely MRKH. The other day, I had a patient who is like MRKH used to be picked up after they used to get married, and whatever was the reason, the couple would come and the girl would tell that she's getting her normal menstrual cycle, but examination under anesthesia would show there's a very shallow vaginal dimple or pouch, and then you're not able to on ultrasound doesn't show any uterus, but both the ovaries are fine. So in those cases, we can definitely give them an option of what you call is we can give them an option of neovagina, where it is it's an operative procedure where we can, at least she can have a normal coital life after marriage. Yes, of course, then comes your surrogacy, but still we can give them an option of uterine transplantation. Maybe for it it all depends on the affordability of the patient and tissue rejection. So many factors are important in that.
Thank you. Thank you very much. And another question is, ma'am, after the transplantation, can lady conceive? If so, when she can conceive? Dr. H.V. Sudhamani has asked this question.
Yeah. See, usually after after the transplant, we need to really see for all those signs of the donor as the recipient complications. We have to address all those complications, and at least a year or so we tell them when the the regeneration of the tissues and all that happens. So that is the time when we tell them they are advised, it is said in the books, as they say, that minimum of 1 year to 2 years onwards they can plan for pregnancy.
Okay, ma'am. Another question is, after mimectomy, how long patient should wait for conceiving?
See, usually here in mimectomy, the importance is why we are concerned is we want a good scar where tissue healing is proper. And once you have a good scar, then we are more, confident to take the pregnancy to the term without any complication. That is our whole concern about the mimectomy scar. So we do advise patients to at least give a gap of 4 months where the proper healing happens. That is as like any other cesarean scar. Yes, of course, if it is on the fundus or on the upper segment or anything, if the bleeding is taken care, good closure during surgery, that ensures that you have the integrity of the scar is most important. Now, after we have seen cases that they have got mimectomy done and we tell them to avoid pregnancy. Initially, we were telling almost up to 1 year or 2 years, a decade back. But we have seen nowadays they are coming up within 6 months. They come to us with the positive pregnancy test, and they have been able to continue with the pregnancy without any complication further. So here we have to individualize the patients depending on the patient. Yes, the surgery part, integrity of the scar, and then so minimum on an average we tell about 6 months time.
Okay, ma'am. Thank you very much. Another question is, what percentage of adenomyosis patient conceive normal?
Yeah. See, what it was said is almost 28%. The patients having the normal uterus and the patients having adenomyosis, there is reduction of almost 28% in the pregnancy outcome. So there is the percentage that it definitely, adenomyosis reduces about 28% reduction in the conception and definitely the pregnancy outcome. So almost you can take it as 30% reduction due to adenomyosis.
So I hope the delegates have got their answers. And ma'am, I could not find any other questions. So if you allow me, then we can conclude this session.
I thank Shield Connect team for this wonderful academic feast, and let this good work continue, and let more and more clinicians, postgraduate students, as we are in always in a state of learning. So we hope you continue to do this saga further. All the best. Thank you once again.
Thank you very much.
Thank you all the delegates for their time.
Yes, ma'am. Thank you very much, ma'am, for your valuable time in our platform also. And in future also, we will look forward from some valuable session from you. And we will try our best to continue this knowledge session with all the medical fraternity. So thank you, madam, and have a good day, ma'am.